Hey everybody, it is Dr. Leith, and I'm going to go over the obsessive compulsive disorders. So, first we need to start with what are obsessions and what are compulsions. And obsessions are intrusive thoughts or beliefs or ideas that kind of insert themselves into the person's mind, right? They're intrusive thoughts. The person tries to control them, eliminate them, reduce them, ignore them, but it's really difficult to do that. So they're really strong thoughts, they're really loud, and that's where the obsessions come from, right? They're obsessed with this. I can't help but think about getting sick. I can't help but think about, did I lock the front door? Is the oven off? Are my kids safe, right? So they intrude, right? They're kind of injected into the person's mind, and that can kind of be disruptive, right? The person's sitting in class, they're at work, they're at church, they're wherever, and they get these thoughts and they can't ignore them. So that's why I use the word loud, right? They're loud, you can't turn it down. And that's distressing enough. And compulsions are behaviors. They're repetitive behaviors, very rigid, and they're usually used to quell the obsessions, right? So compulsions will often reduce the obsession. So I have the thought of, I'm going to get sick, this place is not clean, so then I very rigidly wash my hands, sanitize my hands, and then this goes down, but then it comes back up, and I'm doing this over and over. And that's how you wind up as a person who their hands are like really raw or injured, or they're late, or their work is poor, because between the obsessions and not being able to focus and the time spent doing the compulsions, there is your interference in that person's life. So for OCD, which everybody has heard of, you need one of these or both, and usually there's going to be both. All right, so obsessions can come with compulsions, or they can come without compulsions. When there's no compulsion, the person is just obsessing, they're ruminating, it's interfering, and they're kind of white-knuckling through it until it passes. Compulsions can help reduce it, and a person can also have compulsions without an obsession, and that would be things like hair pulling or skin picking, which we're going to get to in a minute. Now with OCD, again, everybody has heard of it, and it's a term that everybody kind of uses, or many people uses, right? I'm so OCD about my work. I'm so OCD about my collection. I'm so OCD about going to the gym, right? And people have peculiarities. It's always a hard word to pronounce, isn't it? But people have oddities, and just because you like things a certain way, right? So you want to put all your coffee mugs so the handles point due north, or you have kind of a bedtime ritual where you need to go up and you brush your teeth and wash your face, and then you set the air a certain way, right? Doing that is not obsessive compulsive. That doesn't interfere. It might make you kind of rigid, right? Maybe a perfectionistic, things like that. But this is where it's interfering, right? Quite a bit. It's very time consuming, and the person is trying to not think about whatever the thoughts are, and they're trying to stop the compulsions, but they're in such a cycle that they can't. As I said, most people will have obsessions and compulsions, and there's a lot of anxiety, right? Remember, in the last video we talked about anxiety being rooted in fear, and the same here. Sometimes the person is able to identify, such as the case of having obsessive compulsive disorder around illness, right? I'm afraid I'm going to get sick. I'm afraid someone is going to break into my house. So obsessive compulsive revolves around the idea of prevention. That's why I do the compulsions. I wash my hands so I don't get sick. I check the locks 7 times because that's the number that makes me feel secure. Sometimes there's no more or no less meaning to it than that I do it this many times, or I do it in this fashion or with this method, and that's what calms down the anxiety and fear. Most of the time, clients will recognize this as being irrational, and they want to resist it. It occurs in adolescence. That's when we start kind of seeing it sprout up, but there's no hard rule with it. And the symptoms can wax and wane, right? When things start picking up and the person gets anxious, right, we start seeing more of the symptoms for this. And when things are good, we see less of it. But OCD is definitely something that is manageable through counseling, and of course, in the extreme cases, with medication and counseling. But a lot of it is learning to control those thoughts, learning, again, mindfulness, not to keep shoving that down everybody's throat, but mindfulness has been linked to a lot of really positive outcomes. But understanding those thoughts, being okay, what if something did go wrong, right? Nice existential or ACT focused counseling, identifying thoughts, and most of the time your clients will understand what an irrational thought is. The problem is, how do I stop having them, right? And that's where you're really focused on accepting the present moment, doing the mindful breathing, mindful thoughts, right? And just being aware of how you're feeling. And sometimes you have the thoughts, and let's see if we can urge surf, that is, how long does it take for the thought to go away? The most common one is the fear of getting sick or contamination. There's doubts, such as, did I hit somebody with my car? Did I turn off the stove? Did I lock the door? And some of the compulsion, some of the rituals can take a very long time. It can take hours. Moving on to a new diagnosis for the DSM-5 is hoarding disorder. And it's just like it sounds. Everybody has seen the show, and I think mental illness is not always. In fact, it's very rarely portrayed accurately on TV. But hoarding was portrayed fairly accurately. Difficulty parting with items, right? And so the person winds up accumulating a lot of stuff. They don't want to let go. So some of the questions that you're going to ask when you think there might be hoarding is it with everything, or is it only with some things, right? Because people collect things. I have collections of things, and I have, when I was 10 years old, I started collecting comic books and collectible cards and stuff like that, and I still have them, right? Granted, they're like in a box up in the attic, but they're still there, and I don't want to throw them away because I have a lot of memories with them. With hoarding, we're talking about you're keeping things that most likely won't have sentimental value to them, or it's hard to imagine there being sentimental value. So a person wanting to keep all of a deceased loved one's jewelry, okay, that's not necessarily hoarding. A person keeping every newspaper that they've ever read, now we're kind of thinking maybe there's something here. Or keeping every mason jar, because what if I need 100 mason jars, right? And then when it starts interfering with the person's life, but this disorder is interesting, again, because it also includes not only interference with social, academic, professional, and interpersonal life, but it also includes if the person causes an impairment in their living situation, meaning that they have accumulated so much stuff that it is an unsafe place to live, right? And so many times the person, they want to keep things because there's an irrational thought that maybe I'll need it later, and what if I don't have it, or I'm going to keep this because this was the day that such a wonderful thing happened. And so they wind up accumulating all of this stuff, right? They're not actively out seeking it, right? And that's maybe what would separate it from OCD is I need to go and get every mason jar. It's more that I'm keeping everything, and I keep the pizza box that that came with the pizza we ordered with my first study group, and I always want to remember my first study group, and so it builds up and up and up and up. Some of you may have seen that show with Marie Kondo, right, where does it spark joy and all that? And there is actually some really cool evidence that her method works, right? What she was doing, and this is not to discredit her at all, is not a novel idea. Many times in the treatment of hoarding, the person needs to touch the object before they'll part with it. And this is where a lot of confrontation comes up from your basic skills, right? So you're asking, do you really need this cup? And if you just ask, or if you try and throw it away, the person will say, don't throw it away. But if you let them have it, right, hold it, look at it, now tell me, do you really need this cup? They can begrudgingly let go of it. But the pattern is always kind of that way. I need to hold it, investigate it, and kind of come to peace with it, which I think is the healthy way of treating this disorder, instead of just going in and, as much as family members probably want to do that, going in and just clearing everything out, is to involve the client with the decluttering process. When you're treating it, you're going to have the individual make essentially piles. Like, here's stuff that I want to keep, here's stuff that I'm going to donate, stuff I'm going to throw away. But if you're going to keep it, it has to have a place, right? If you really want to turn it up, because maybe they have a whole lot of stuff, it needs to have a place and it needs to have a purpose, right? But involving them is the critical component, and it's not abnormal for that person to have some hesitation over letting go of certain objects. And again, that the other reason for including them is we don't know what has historical significance, right? Is this truly a family heirloom, or is this something that you remember that day and it's you're just kind of keeping it because that's part of the disorder, right? The goal is not to get rid of everything; it's to get rid of the things that the person doesn't really need or want, and helping them find other ways to connect to those positive feelings and memories. Trichotillomania, which probably everybody has heard. So if you work with youth, it typically occurs with teens, so school counselors and youth counselors, you're probably going to be the front line for this one. And so with this, it's hair pulling. And this is an example of a disorder that has compulsions but not obsessions, right? The person's not obsessing about pulling their hair. They're just kind of doing it, right? And they go up, and it can be what's called focused or unfocused, right? And focused would be I'm intentionally doing it, right? I maybe have a ritual with it, right? I go home, I put on music, I close the door, and I just kind of go to it. Unfocused would be kind of like when you're in the car and maybe you bite your nails or something like that. You're not intentionally doing it. It's not a thought at the front of your mind, but you're doing it. They're just kind of pulling. And the hair pulling, and this is how the treatment would look. Well, hang on. Before I go into the treatment, the rest of this order is they want to stop but feel that they can't. So they're aware it's a problem. They've tried to stop, but it's been unsuccessful, and they keep pulling the hair. And some of the consequences are going to be a lot of like the shame with it, right? It causes maybe the receding hairline or patches in the person's hair. Excuse me. And so treatment for this is a really detailed conversation about it. So it's a lot of, well, when you do it, do you have a ritual, right? How do you do it? When you pull the hair, where do you pull it from? Most of the time it's from the head, from the hair. But it can be from other parts of the body, the arms, the legs, the armpits, the stomach, wherever. Do you use tweezers or your hands? Do you pull one hair out at a time, or is it a group? It's probably really, really unlikely that someone is going by the fist, right? But it could be the case that someone is pulling out 2, 3, 4 strands of hair at a time. And then it's things like, do you pull it all the way out, meaning like from the follicle, or do you break the hair? What do you do with the hair when you're done? And it's not uncommon for people to say things like, I just throw it away, I throw it on the floor, I put them all in a pile and then flush them down the toilet. I put it in my mouth. I play with it in my mouth. I roll it between my fingers. I chew it. I chew it but don't swallow it. I do swallow it, right? And so lots of different things, but this is all part of the process, understanding it. And that's a theme that I have found working with many disorders, is having a very detailed description of what happens, because that gives us as clinicians more information, and it gives them more insight into what's happening. And for both of us, it gives us places where, like, what can we change first, right? We know where they're coming in. I keep pulling my hair and I can't stop. And we know what the goal looks like. The person stops pulling their hair. So where in between those two things can we start implementing change? Do you do it in front of a mirror? Do you use tweezers? I may have already said that one. Do you do it in front of a mirror, right? Because maybe they're pulling hair from specific areas or they're trying to diffuse the problem. So anxiety management, behavioral issues, right? So putting a very common one, putting tape around your hands, right? Removing tweezers from your room, removing mirrors, right? And maybe this may be easier when like parents or guardians are involved, right? Versus when if they're a college student and it can be a little more difficult and they can go out and get those things. But one of the assumptions about working with clients is what? They're trying their best, right? So removing all of that stuff, not allowing it there, being aware of what you're doing with your hands, especially if it's unfocused. And you might be giving homework like journal assignments, right? I need you to write down how you feel at each hour or every couple hours. So that way they get a handle on what they're doing behaviorally and how they're feeling emotionally. Excoriation is very similar. It's a new diagnosis to DSM-5, though it has been symptoms of other disorders in the past. This is skin picking, right? And so for this, I don't have images here, but if you want to see what it looks like, you can certainly Google it, right? Put a little warning that some of this, the first, anytime you Google a case study, you're going to get the most extreme thing. If you Google this, you'll get fairly extreme images. But skin picking, just, kind of like when you pick at your cuticle. And I say that like I'm a nail biter, right? So I kind of will pick and things like that. And the person winds up giving themselves cuts and scars and blemishes. And it's usually on the arms, but it can be anywhere. And like trichotillomania, they have tried to stop. The problem here, aside from the picking, is there's a risk of infection, but there's also the person feeling embarrassed that my arms are all marked up or my face is all marked up and trying to cover that. The person has tried to stop and has been unsuccessful. And so with this, the person is very, very aware of their body. And so when they put their hands in their pocket, they're very aware if anything snags on it. So have you ever done that? Or here, since there's hand sanitizer everywhere, if you have a cut on your hand, small little paper cut, didn't even know you had it, what happens when you put on a hand sanitizer? It burns. Or if you ever had a skin tag or like a hangnail and you put your hand into your pocket and it catches, right? They're hyper aware of all of that. So they pick, and then there's some bleeding, it stops, a scab forms. Now they're hyper aware of the scab, so they keep picking that, right? And so they pick and pick and pick and have a hard time. So again, like with trichotillomania, it becomes a method of how are you doing this? Is there a ritual? Is it intentional? Or is it mindless, meaning you're just kind of doing it? And how can we check in, right? How can that person check in with themselves to help reduce it and then ultimately work towards stopping it? So managing whatever anxiety is there. And finally, this disorder's been in the DSM, but in DSM-5 they moved it here from the eating and feeding disorders. And so body dysmorphic disorder is a preoccupation with a specific part of the body. And I'm really interested in this disorder, as I've said in the past. I'm really interested in eating and feeding disorders and body image stuff. And so this one is really interesting. And so this is where a person thinks, my eyes are too far apart, my ears are too big, my nose is too small, whatever it might be. But it's a specific part of the body. Then the person does repetitive behaviors, right? They're looking in mirrors or they're doing mental acts like social comparison. And this can include preoccupation with one's weight. Now that usually is reserved for anorexia, but the difference here is that the person doesn't have the eating behavior that anorexia has. With anorexia, the person dislikes their body weight and they're afraid of gaining weight, and so they restrict their dieting. They starve themselves. With body dysmorphic disorder, it might be, I don't like my weight, I'm afraid of gaining weight. I have the assumption that nobody likes me because of my weight, but they're not engaging in the restrictive dieting of anorexia. And this can be with anything. It can be with a person's chest, their butt, their stomach, their arms. And this is what leads to getting surgery after surgery after surgery. A case example, or two of them are Michael Jackson with his skin and his nose. And then there's a great documentary, which I'll put in the module and you guys can watch if you're interested, called The Man Whose Arms Exploded, which is about a guy who had muscle dysmorphia, which is the next point here, right? So he was obsessed with his biceps, right? The size of his biceps. And so he kept taking steroids and working out, and he had like these disproportionate arms, right? And then eventually, led to a really severe infection. They don't actually explode, but muscle dysmorphia, which is a new specifier for the DSM, which is somebody having the fear that they are too small, they're not muscular enough, and they want to be bigger. So what do you think this leads to? Yeah, steroid use, exactly. So this is more notably in men than in women, but not exclusive. But it does lead to anabolic steroid use because a person feels like they're very, very small or too skinny, not muscular enough. And then they get bigger and bigger and bigger, and they wind up still feeling like they're too small, right? So a specific part of the body that a person is sort of obsessed with and attributes all negativity to. If you watch the show Botched, I promise you several, if not most of the people on that show have some form of this. It just depends on the part of the body, whether it's breasts or chin or legs or butt or ears or whatever, right? It's a specific piece. That's going to do it for this video. I hope everyone's well. If you have any questions or concerns, let me know, and I'll talk to you again soon.